Welcome, everyone, to this symposium entitled Roles and Opportunities in Prevention and Care for Adolescents. I'm Patricia Dittis with the Division of Adolescent and School Health at CDC, and I, along with Ali Kaur from the Division of STD Prevention, will be moderating this session. I'd like to remind you that there will be a live question and answer session for this symposium on Friday, September 18th at 2:30 p.m. Feel free to put your questions in the chat box as you listen to these talks. Our first speaker today is Dr. Rob Stevenson. Dr. Stevenson is professor and chair in the Department of Systems, Population, and Leadership at the School of Nursing, University of Michigan, where he also directs the Center for Sexuality and Health Disparities. His work focuses on the nexus between stigma, violence, and HIV prevention for vulnerable populations, including transgender communities and same-sex couples. Dr. Stevenson?
Thank you very much. Hello, everyone. It's nice to see people virtually. Today, I'm going to be talking to you about some of the issues involved in reaching transgender youth with sexual health services. And what I really want to talk about today is a case study that we conducted recently of using a telehealth intervention to reach transgender youth in the US with HIV prevention services. I'm going to present those results to you today, but then I'm going to talk about how we can extend the recent advances in telehealth innovations for sexual health services for transgender youth in general. But before I do that, I want to provide some of the data to contextualize the sexual health issues that are experienced by transgender youth in the US. So first of all, from an HIV risk lens, a review conducted in 2015 showed that transgender identifying individuals experienced 3 times the HIV diagnosis than their cisgender counterparts. And similar to the racial disparities that we see in HIV among gay, bisexual, and other men who have sex with men, these disparities between transgender and cisgender are not necessarily fueled by differences in risk behavior. They're much more shaped by structural vulnerabilities and layers of transphobic stigma that put transgender individuals into context of risk. So, for example, transgender individuals face higher rates of unemployment, underemployment, incarceration, lack of health insurance, and lack of access to quality, culturally appropriate healthcare. And all of those things systematically and synergistically work together to put transgender individuals into context of increased HIV risk. And by that, I mean greater levels of participation in transactional sex, substance use as a maladaptive coping strategy for stigma, and greater risk of engaging in condomless sex. Moving on, though, specifically for STI risk, this year there was a really nice systematic review published by Van Gerwen et al. That looked at the prevalence of STIs specifically for transgender individuals, and rather uniquely was able to break down the data for trans feminine and transmasculine individuals. And looking at the screen starting on the left, you see that the rates of syphilis for transgender women range from 1.4 to 50% in some samples, and much lower in transgender men, only ranging up to 5%. For gonorrhea, you see a similarly high levels among transgender women, up to 20%, and as high as 10% for transgender men. And then for chlamydia, again, you see a very high level, about 1 in 4 for trans feminine individuals, and then about 1 in 10 for transgender men. And I think the results of this systematic review highlight 2 really important points. One, from a programmatic perspective, the very high levels of STIs that are experienced by transgender individuals. And these are related to many of the reasons I just mentioned about HIV risk, the structural stigmas and the presence of transphobic attitudes that prevent the provision of quality services. But look at the range of estimates here. There are clearly some issues with sampling, often relying on very small clinic-based samples. And in terms of STI research, we're really behind the curve in large national studies that truly understand the STI risk for transgender individuals. Now, I said I was going to talk about transgender youth, and so far I've talked about all transgender individuals. And that's really because we have a lack of data for transgender youth. But for youth in general, we know that youth experience a disproportionate burden of HIV risk. In 2015, it's estimated that over 60,000 young people, that's those aged 13 to 24 in the US, were living with HIV. But what's important is that approximately half of those were living with undiagnosed HIV. And so there's clearly a need to develop adolescent-friendly services for transgender youth that can tackle sexual health issues. We also know that in terms of screening and prevention behavior, that transgender youth have very low rates of HIV testing. Very few transgender youth manage to meet the CDC minimum recommendations for HIV testing. And again, it's because of these structural levels of stigma and vulnerability that prevent the provision or access to quality HIV prevention services. And there's also high rates of condomless sex and low rates of PrEP use that put them at particular vulnerabilities for STIs and HIV. So what I want to talk about today is specifically how we can use a telehealth intervention to surmount some of these problems. Now, we all know about at-home testing for HIV. It was FDA approved in 2012. You can buy them, from most pharmacies. You can buy them online from Amazon. People can do them easily at home. But there are some issues associated with that. The extent to which people fully understand the results. What does a reactive result mean? But this is a particular concern for young people. It might be their first time taking an HIV test, and there may be difficulties comprehending what the results mean. You also miss the opportunity for counseling and to actually do some prevention promotion. And then for those who have a preliminary positive reactive result, you miss opportunity for linkage to care. So what we did in this study was to think about how can we put all of those services in the home for transgender youth through telehealth. Central to our intervention was using motivational interviewing. Motivational interviewing, and I'm sure many of you know this already, is a different way of talking to people. It's when the client and the provider work together to set a goal for the client to work towards. It's not like a routine provider-client visit where the provider essentially tells the client what to do. In motivational interviewing, you work on enhancing the motivation for the client to enact positive behavioral change. Importantly, you give them the behavioral skills. You ask them to reflect critically on their past behavior and to think about how changing behavior might lead to a positive future. And central to motivational interviewing, is goal setting short and long-term goals for sexual health that people can work towards. So we put all of this together into one intervention called the Moxie Intervention. And Project Moxie is essentially using telehealth, talking through Zoom, just like I'm doing to you now, while people test at home for HIV. So I want to talk about what results we found and then how we can extend this to all sexual health services, particularly STIs. So a quick overview of our study's design, starting from the left. It was a small pilot randomized control trial. In the control arm, we just sent them an HIV test kit, no human interaction. They got an HIV test kit, they logged on, and they reported the results. But in the intervention arm, we sent them an HIV test kit, and then we used a HIPAA-compliant Zoom, like we're doing now, to talk to them, to actually watch them do the test, to use motivational interviewing techniques to think about behavioral change. We recruited 200 transgender identifying individuals aged between 15 to 24 with no previous HIV diagnosis, who were willing to be mailed an HIV test kit and resided in the US. They did surveys at baseline, at 3 months, and at 6 months. It was an all online recruitment. This is an example of one of our ads. We were aiming for transgender identifying and gender non-binary identifying individuals. We recruited through a whole range of social media outlets. So this is what it looked like. I actually want to walk you through the practicalities of what this looks like. So you click on the ad, you see the ad on Facebook, you click on it, it takes you to a landing page. You have an electronic consent form, and then it takes you to a portal. And here's a picture of one of the portals where it stores all your information, your address, it tells you when to do your surveys, how to log your results, and all of those kind of things. Then from there, and this is what's really important, is that you were able to schedule when you wanted your HIV testing and counseling session. We Working with time zones across the US was an interesting challenge, but our tactic was to meet the population where they were and to provide as many available time slots as possible. And interesting to us, popular time slots were lunchtime when people were on breaks, but really after 9 p.m., right through between 9 p.m. and 1 a.m. is when people really wanted to do an HIV test, and that's what we provided. So this is another example of surmounting, the practical barrier of having to work within regular office hours of a lot of HIV testing services. Here's an example. These are not participants. These are two of my research staff who were willing to pose. So on the left-hand side, you have our counselor. Notice the counselor has a screen behind them. And then on the right-hand side, you have the client and their HIV testing kit. And it was about a 20 to 25-minute session, very similar to CTR, where they watched the person do the HIV test. While it was cooking in the background, they used MI techniques to help them think through their sexual behavior. In terms of results, people logged on. In the control arm, people logged on and provided their results. In the intervention arm, we had their results in real time, and we had a strong linkage to care process. If people who reported a positive result received a call within 24 hours, and another call at 7 days, 30 days, and 90 days. Because we knew the zip code of everybody, because they registered it when they registered for the study, we were able to use 212.org to look up the local services. So what's nice about this is when we call them for our linkage to care call, we were able to say, in a non-creepy way, we know where you are. Here's some services you can go to. And we could use functions such as screen sharing to show them the transports they could use to get there, help them make an appointment. And because of this very not aggressive, very hands-on linkage to care approach, we were able to get 100% linkage to care among our preliminary positives. I mentioned we used a range of recruitment techniques. So there's some of the places we recruited from Facebook, Instagram, Twitter, Tumblr, Craigslist. What's really interesting here is the differential recruitment and retention rates. The message here is that you get a lot of people on Facebook, but you also have a large dropout rate. You might not get as many people on Twitter, but they do stay in your study. And so there's a paper available where we actually worked out the economics of that. If anyone's interested, my email is at the end of this presentation. I'm happy to share that with you. Just to remind you of the flowchart of our study, working again from the left, we had 329 individuals create accounts. Approximately a third of those accounts were fraud, and we have a very strong system working on the work of Jose Baumeister with his gold standard for detecting online fraud for online studies. So we were able to weed out our fraudulent accounts, and these were, mainly people who were trying to register 3 or 4 times. We randomized 202 people, and we did a 2-to-1 randomization. So double the number of people got the intervention, and as I mentioned, they did surveys at 0, 3, and 6 months. The great thing is, people love this. Let me back up by saying, in the intervention arm, only half of the people opted to do the intervention, which is not ideal. And it really fell into 2 buckets of people. Those who did the intervention and loved it, and those who didn't want to do the intervention, they just wanted the testing kit. So let's start with the first bucket. Those who did the intervention, which is about 60 of the 120, overwhelming positive response. 98% reported that they were satisfied with the video chat counseling. 98% reported that the kit was easy to use. The VC software, that's the secure HIPAA chat service we use, was easy to use. People would said the session time was just right. They'd recommend it to other people. Those who didn't do the video chat and just wanted the testing kit, we actually interviewed some of those later, and it came down to privacy. They didn't want to actually speak to someone they didn't know. They said they'd much prefer an instructional video that could help them. So this is a really interesting finding, is that there really seems to be 2 types of people when it comes to telehealth, those who are comfortable and those who are not, and we might need to tailor an adaptive telehealth service for those. In terms of how it impacted sexual behavior, in the control group versus the intervention group, we had very low levels of willingness, well, not that low, but a third willing to use PrEP. But it increased significantly in the intervention group, but it didn't increase in the control group. And I think this is one of our primary findings, that by talking to people and using MI through telehealth, we could shift people's goals towards wanting to use PrEP. We saw reductions in condomless sex in both groups, which was interesting. And I think that's just the act of taking an HIV test is often make people reflect on their behaviors. And we saw similar changes in alcohol, tobacco, and other drug use combined with sex in the last 90 days as well. So there is just impact of providing people with an at-home testing kit. So how do we extend this to STI testing? Because I know I'm running up on time. So I think Project Moxie demonstrates that you can recruit transgender youth online. They're often marked out as a very hard to reach group. They are a hard to reach group, but with sensitive community-based recruitment techniques, you can recruit this population to telehealth. We know that home STI testing is also becoming increasingly common. It's very simple to, just as we send people HIV testing kits, to send people STI testing kits, have them self-collect their samples and they go to a lab. I'm going to call out another presentation that's happening, or it may already have happened, by Sullivan et al., who was actually presenting some of our other work where we actually use telehealth to provide STI testing for male couples. Hugely successful. People love the idea of having an STI test in their own home. So what does this all mean? If you're going to do telehealth and you're going to recruit people, you've got to keep an eye on fraud. Look for the work of Jose Baumeister for the gold standard to do this. Also email me if you've got questions about how to do this. We found success with diversified recruitment. Just putting ads on Facebook often doesn't get the right population. We used a whole range of things from Reddit to Tumblr to Craigslist to friends referrals, and we're really able to get a relatively diverse population. There's no technical barriers. We had no dropped calls. Every person we spoke to said the software was easy to use. We never had an issue of privacy, confidentiality, and a call interrupted by a family member, because we sent very careful instructions ahead of time of how to set up their telehealth session. And high levels of satisfaction. People love the idea. Well, half the people love the idea of doing this, the comfort of their own home. The other half didn't want to talk to a stranger about sexual health, which I think is natural, and they still wanted to use telehealth, but they wanted to do it in a different format. So in summary, in trying to address the barriers to providing sexual health services to transgender youth, I think we need to think about innovative telehealth mechanisms and to use the current technology in e-health and m-health to reach out and bring transgender youth, this vulnerable population, into sexual health services. So I'll finish there. I'd like to thank the funders of this, NIH and ICHD. Thank you for that. And here's my contact details. I'm happy to take any questions via email or in the question and answer session on the 18th of September. Thank you.
Our next speaker is Michelle Tropper. Ms. Tropper is the Director of Clinical Programs at Health Efficient. She is responsible for coordinating and leading key quality improvement activities and projects for the network in collaboration with community health centers and other partners. She recently led several of the organization's learning collaboratives to improve documentation in electronic health records for self-measured blood pressure monitoring, adolescent sexual history assessment, and colorectal cancer screening. Ms. Tropper has over 25 years of healthcare quality improvement experience and has spearheaded numerous community-based outreach, research, and educational initiatives to improve public health. With that, Ms. Tropper.
Thank you, Allie, for that introduction. I'm delighted to be here to speak with you about one of those quality improvement initiatives that we did recently in collaboration with the Centers for Disease Control and Prevention and the National Association of Community Health Centers, as well as several of our health center partners. So this is about sexual health counseling to reduce risk in adolescents and young adults. Details drive success. First, a little bit about my organization, Health Efficient. We're a not-for-profit, mission-driven organization that is headquartered in New York State. We're heavily concentrated on the East Coast, and we're owned and operated by and for our member health centers. We have over 35 members in 7 states and Washington, D.C., and currently all of those members are federally qualified health centers. We support the HIT needs of our members, including using data for quality improvement and revenue cycle. Here's a map that shows you our footprint. As you can see, mostly concentrated in the Northeast, in New York and Connecticut, New Jersey, Maryland, DC, and Pennsylvania. And then we also have some health center in New Orleans and Florida. The CDC and NAC approached us because of our experience working with the health centers, and they're looking at their electronic health records to use the data for actionable quality improvement. And the purpose of this project was to implement sexual history taking and age-appropriate behavioral counseling for sexually active adolescents and young adults in primary care. We saw the need to identify using a common or a standardized evidence-based sexual history taking tool. There's a lot of variation in community health centers about how this information is gathered and whether it's even gathered at all. So we set out to assess what types of tools were being used at our health centers, and then encourage them to select an appropriate evidence-based tool that they can use to take sexual history, implement workflow and EHR changes for sexual history taking of adolescents, and then also implement workflow and EHR changes to provide and code for appropriate behavioral counseling for sexually active adolescents. Another goal that we set was to take at least 100 sexual histories for patients between the ages of 13 and 24 in a one-year period. This was a reasonable goal given that prior efforts to do a similar type of intervention proved challenging to get those sexual histories taken. So the case for change, and this is what was our driving force behind conducting this intervention. The sexually active adolescents and young adults lack access to behavioral counseling. And providers also lack access to tools and support for taking adolescent sexual histories, assessing risk, and offering appropriate behavioral counseling and related services. At-risk sexually active youth also face increased risk of sexually transmitted infections, pregnancy, and other disadvantageous outcomes. In fact, the act of taking a sexual history and asking questions of the youth is in and of itself an intervention, and provides an opportunity to probe and ask additional questions of the teens about other risky behaviors. The effort to provide adolescent behavioral health and counseling services is substantial, as well as the cost to the system for not offering them. So we identified 4 health centers to partner with for this initiative. And you can see here on the map where they were located within our network. So we chose 4 of our health centers that had substantial adolescent populations that would be able to identify some pilot providers to test the intervention and sexual history assessments, as well as to conduct some motivational interviewing with the teens that they were taking assessments on, and provide counseling based on the information provided in the assessments. The 4 health centers that we worked with were Whitney Young Health Center in Albany, New York, Open Door in Port Chester, New York, First Choice Health Center in East Hartford, Connecticut, and Zufall Health in Dover, New Jersey. And you could see the total health center populations at the time that we implemented this intervention, which was between 2017 and 2018, over a one-year period. The types of sites that were chosen were urban and school-based, as well as primary care, and also an OBGYN women's health program. In terms of the sexual history taking instruments that were looked at and evaluated, we worked with the Centers for Disease Control to identify evidence-based instruments, and they also encouraged the health centers, if they had other tools that were validated, that they could use those as well. So there were 7 instruments that were assessed, including those on this list. And I will also share with you a summary of the practices, settings, and the study population, as well as the tools that they selected to implement for sexual history taking. The tools that were selected, for the most part, were based off of the Bright Futures form. So at First Choice and Zufall, they both selected initially a Bright Futures form. Zufall switched to a Kaiser Permanente form based on team members' input. And then at Open Door and Whitney Young, they both used the eClinicalWorks Sexual History Smart Form. All of these health centers do use eClinicalWorks as their electronic health record. And that made it easy for us as a health center control network to be able to look at the data that they were collecting on a monthly basis and work with them to identify areas that they might want to strategize on for improvement. So although eClinicalWorks does have a sexual history smart form that asks the questions included in Bright Futures, it's only available in English. And given a high number of Spanish-speaking patients at both First Choice and Zufall, they liked having the flexibility of a form that was available in both English and Spanish. And the Bright Futures modified form used at First Choice and the Kaiser Permanente form at Zufall was available in both languages. The participating providers included a mix of pediatricians, nurse practitioners, family physicians, and at one of our health centers, they also included OBGYN physician and OBGYN nurse case manager, and that was with the Women's Health site that also participated in the project. You could see that in terms of the percent of unique adolescent patients seen by the pilot providers of all adolescents in the health center, that we had between 20 and 58% of the adolescent patients seen in the practices, mostly around 20% for the participants. Whitney Young had higher percentage of adolescents seen by the pilot providers. I already mentioned the pilot providers' practice settings. They did include primary care, school-based clinics, and family medicine, as well as OBGYN. So one of the things that we did in assessing the workflows and how the practices were conducting sexual history taking and also documenting the behavioral health counseling in the electronic health record was to look at the workflow in the practice and see the process that the health centers went through in order to collect those sexual histories and also document the behavioral counseling that followed. And you can see here the 3 different roles that we looked at in terms of medical assistant or physician's assistant, pediatrician in this particular practice, and the parent. And while there's some variation in these workflows, for example, in this one, the parent is present for some of the initial assessment taking, where the MA takes the patient's vitals, height, weight, and starts an initial interview with the patient. The patient's asked to fill out a paper teen risk questionnaire. While the patient is filling out that questionnaire, the MA is engaging the parent in conversation to give the patient some privacy and not have the parent overlooking their shoulder while filling out the questionnaire. The MA then documents the patient's responses from that questionnaire in history of present illness in the EHR and conducts the PHQ-2. If the PHQ for adolescents or the PHQ for adolescents or PHQ-9 is administered to the patient if they respond positively to the PHQ-2, and if not, after that particular questionnaire, the EMA will enter the information into the electronic health record based on patients' responses, bring the completed survey to a provider for sign-off, and then completes the patient survey that the provider has signed off on into the EHR. At that time, the provider meets with both the patient and the parent, and the provider asks parents for their concerns. And then the provider excuses the parent from the visit and proceeds to confidentially meet with the patient. In another practice, the assessment process is done without the parent in the room. So it really varied based on the practice and also the age of the patient as to whether or not the parent was in the room at the time the questionnaire was being administered. But at all times, the practices were very conscious of parents' presence and providing a space for the patients to be able to respond to the sexual history assessment in a confidential manner. After the parent would leave the room, the provider then would review their responses to the teen survey and add that documentation into the EHR. And if the responses then require behavioral counseling or motivational interviewing, the provider would counsel the patients on risky behaviors, encourage and provide appropriate follow-up, and then document the counseling using an appropriate code for the visit per AMA guidance. So we did provide some AMA guidance to the health centers on how they can code for these visits, and there was some training that was done for that as well. And then once the exam was completed with the patient, then the parent would come back into the room, be told what additional services were needed, such as HPV vaccine, and the vaccines would be given, and any additional follow-up would be carried out at that visit. So that gives you like a really nice idea of how the workflow happens in primary care. And it was pretty consistent for each of the sites that participated in this. So one of our interventions were we provided some training on site to the pilot providers on motivational interviewing. And the motivational interviewing provided questions and suggestions for speaking with the teens about their risky behaviors. Additionally, the health centers tested and selected tools that were most suited to them and their practices. So, you saw that in one of our health centers, they actually started out with one tool and then switched to another because of provider preferences. And we also provided that information about AMA recommendation for CPT coding for MI counseling. The AMA guidance helps staff and coders understand how to document provision of the MI counseling given to patients after taking their sexual history. And we also found that working with a coding expert allowed the health centers to build system changes into their workflows and become standard practice. Some of the pearls or change concepts that we identified in this project that are replicable for success. The health centers definitely like testing different instruments for assessing adolescent sexual history. We conducted periodic facilitation calls with each individual health center for data review, and those were more preferable to group discussion calls. And we also found that our pilot providers had higher rates of patients screened for sexual activity and STIs, and more of their patients received 2 or more doses of HPV vaccine. Additionally, the pilot providers were working primarily with adolescent patients, and they were more in tune with the needs of the population. So this could also be part of the reason why we were more successful in those interventions with the pilot providers. Our recommendations for others who would like to replicate this allow for provider preferences and input when choosing assessment tools. If the tools are easy to use and identify risks at a glance, they'll be more useful in practice and more likely to be adopted by providers. Also, identify the key areas for improvement and the necessary changes in workflow. With reinforcement from a clinical champion regarding the changes, sustained practice change will follow. And utilize expertise from the internal resources to help identify necessary steps for sustaining EHR documentation change. The most successful implementation of behavioral health counseling documentation occurred when a coding specialist provided training to staff on how to properly use the codes for behavioral counseling. We were really excited by the results that we got from this project, and this is really the highlight of the behavioral counseling in adolescents screened for sexual activity. This line represents when the motivational interviewing training was given to the providers just between July and August of 2017. And you could see if we look at the first set of data here, which is the pilot providers compared to the non-pilot providers in the practice, that there definitely was a big bump between August and September in terms of behavioral counseling happening for those that were screened for sexual activity compared to baseline and prior to the motivational interviewing training. And this was something that was sustained over time in the practice as we followed the data and their documentation throughout the course of the year. So one training in motivational interviewing, they got the message and then they started to conduct the behavioral counseling. They also were documenting that the counseling was given as evidence-based by CPT on claims. So that's where we got that data from. In looking at the population that we were targeting, we had the 13 to 18 population is the orange in this particular graph, and 19 to 25 is the blue line. And you can see that there was more documentation of counseling with those 13 to 18-year-olds than there was in the 19 to 25-year-olds. And there definitely was a difference between August and September after receiving that training, both on motivational interviewing as well as the documentation of the coding in the EHR. There wasn't too much variation of counseling being given for males versus females, although there were more males that were receiving behavioral counseling than females. And it may be that the providers were just more comfortable providing that counseling to the males, or maybe they had riskier behaviors that needed to be assessed. So it could have been either one of those, but that also was interesting to see those differences. To acknowledge all of our partners in this project and also our funders, the Centers for Disease Control and the National Association of Community Health Centers, and our practice teams who worked very closely with us to examine the data. If you have any questions, please feel free to reach out to me at mtropper@healthefficient.org. And I also am happy to respond to any questions during our Q&A session on September 18th. Thank you very much.
Next up, we have Dr. Joanne Brown. Dr. Brown is nationally certified as a women's health nurse practitioner and a family nurse practitioner, and works at the University Health Service at the University of Kentucky. She joined UHS in 2006 with a primary focus on sexual health. As one of the providers with the UK Transform Health Clinic, she provides PrEP and gender-affirming hormone therapy for students and is committed to providing quality care in an inclusive environment. Dr. Brown is a member of the Kentucky Coalition of Nurse Practitioners and Nurse Midwives, the National Association of Nurse Practitioners, and the University of Kentucky LGBTQ Advisory Board. She is also actively involved in and holds leadership positions with the American College Health Association related to sexual and reproductive health. Dr. Brown?
Well, thank you, Patricia, and welcome everyone to my section of the symposium on the transition from dependence to independence for healthcare. As you noted, I am a practicing nurse practitioner with an emphasis on sexual and reproductive health. I've had the pleasure of working at the University of Kentucky for the past 15 years with young adults there. Prior to, and one of the things that I've discovered is prior to coming to college, most of our students' healthcare encounters have been directed by their parents. When I first started in college health, I was surprised that many of their parents still were directing their college health encounters. Part of our role as college health professionals is to help our students become independent consumers of healthcare. So that certainly involves teaching them how to schedule their appointments, knowing their medications, knowing their allergies, knowing their pertinent family medical history and their personal medical history. I have one disclosure. I am on the Speakers Bureau for Gilead Sciences. But we really can't discuss that transition from dependence to independence without discussing confidentiality. So I don't think it'll come as a surprise to any of the people listening today that is a concern. So we know as children grow into teens and then young adults, their concerns about confidentiality and privacy grow as well. Did your mom and dad know everything about you and everything that you were doing as a teen or young adult? Certainly mine didn't, and certainly I don't think I knew everything about my children's lives. We do know that adolescents and young adults are much more likely to access healthcare, be more satisfied with their healthcare providers and their visits, and share that sensitive information when their confidentiality is ensured. However, about 60% of those adolescents and young adults do not get any time alone with their clinician for a confidential discussion, despite their patient and even their parents' preferences. So if we know how much this impacts their health and their well-being, all of us who are working with this population still have some work to do. The American Academy of Pediatrics, the American Academy of Family Practice, the American College of Obstetricians and Gynecologists, and a number of other organizations all discuss the importance of this private conversation time between healthcare providers and their patient. When I have patients that accompany their college student to a visit, either I or my medical assistant tell them that my routine procedure is to see the patient first alone, and then I will have them join us later if desired by the patient. I try to emphasize to the parent that our goal as college health professionals, again, is to help their student begin to take responsibility for their own healthcare, and I can't do that if mom or dad are in the room. And then discussing with the patient and the parent, the meaning and the importance of confidentiality, the scope of confidentiality protections, and the limitations of confidentiality. And then I'll set the stage with the patient by saying, everything we talk about today is private unless there's something I'm particularly concerned about regarding your safety, meaning you're thinking about ending your life or ending the life of another person, or that someone is abusing you. The link on the bottom of this slide accesses some great patient education and sample letters or agreements that those of you who are working with minors might find valuable. As Patricia mentioned, I'm actively involved in the American College Health Association. I'm the past chair of our Sexual Health Promotion and Clinical Care Coalition. And we put out a sexual health services survey every 1 to 2 years, which serves as an important benchmarking tool. And it means for us to assess our outreach efforts in college health. We started adding some questions about confidentiality and privacy in 2017. Not surprisingly, the majority of people who responded indicated that their patients were concerned that their parents might find out that they were tested or treated for STIs and HIV. We did find in 2019 that still a majority, but fewer respondents indicated this was a concern. I know that when we received our results, we started adding some information on our website and information that went out in presentations that we do for college students that directly address the confidentiality issue and let our students know that their services were confidential. And I think others have done that as well. There are several professional organizations that address confidentiality for teens and young adults in their policy and position statements. One of those recommendations is to include confidentiality protections for adolescents and young adults in the healthcare billing and insurance claims process. So while the Affordable Care Act expanded access to sensitive services for young adults, allowing them to stay on their parents' insurance, health insurance until age 26, and covering some of those specific preventive services like screening for STIs and HIV and cervical cancer, offering a full range of contraceptive methods without that cost sharing, it also presented some challenges. We know that parental involvement often has positive benefits. However, parental notification could put our teens and young adults at risk of either verbal or physical abuse or generate conflict that could actually lead to an underutilization of those same services that we want them to be participating in. Again, we don't want to out our patients by accident. Some of the examples of ways that we could help mitigate this is by exempting contraception and STI care from the EOB, or not sending EOBs when there's no balance due from the policy holder, as is in the case for the no-cost provisions of the Affordable Care Act. The EOB could be sent directly to an address specified by the patient rather than to the policy holder, and making sure that we have laws that allow the patient to consent to what information remains confidential in the billing process. This chart is from the Guttmacher Institute. That was as of June 2020. There are 14 states that have some provisions that serve to protect the confidentiality of individuals insured as dependents. 6 states allow insured dependents to request confidential information from insurance companies directly to them via a written request. 4 states allow insurers to mail an EOB directly to the patient instead of the policyholder. Insurance providers in New York and Wisconsin are not required to send the EOB to the policyholder if there's no balance due. There are 6 states that explicitly protect confidentiality of minors insured as dependents, and 4 states that are specific for minors seeking STI treatment. 3 states, with Washington being the most stringent, have protections for minors seeking any medical service. In Washington, insurers may not disclose private health information, including the EOB, without the minor's authorization. In our sexual health services survey in 2017 and 2019, when we added those questions, only about a third of our respondents said that their state allowed their students to request the EOB be sent directly to them. The other 2/3 of them didn't know what their state law was. So the emphasis is on know what the laws are in your state regarding this. We published a white paper on best practices for sexual health promotion and clinical care in January of 2020 with the intent to consolidate information from ACHA position statements and guidelines on sexual health histories, as well as guidelines and best practices presented by other national organizations to assist colleges and universities in the provision of sexual health services, both in health promotion and in clinical care services, specifically through the lens of public health and medicine. While it's not exhaustive, it provides a resource on a broad range of sexual health topics in college health, and the link is at the bottom of this slide. These are a few of the broad recommendations, such as incorporating how sexual health can promote pleasure and intimacy and not just contribute to STIs and HIV and unwanted pregnancy, as this opens the door to communication with our patients. After all, the primary reason many people have sex is to experience pleasure. So we should include in our routine sexual histories questions about sexual function and satisfaction. We do know that services start when our patients enter our health center, so those first impressions matter, using general neutral terms on forms, having posters, brochures, and other materials where patients can see themselves reflected, sends a message to those with a variety of identities. Many of our students come to campus with a number of experiences of trauma or even experienced trauma at our institutions. So we need to have an understanding of how trauma impacts their daily lives so that we can avoid re-traumatization while we're trying to provide care. This means we cultivate a culture of consent and provide chaperones for any exam where the breast, genital, or rectal areas are exposed. And of course, that we address confidentiality concerns. So we've been asking about the cost of STI and HIV screening since 2011 in our sexual health services survey. Around 50% every year say the cost of all STI and HIV tests are charged to the patient or their insurance. So thinking about options to address that confidentiality is essential. Some of the recommendations and some of the things that other colleges are doing is offering STI, HIV screenings at no cost or low cost, so the student is more likely to be able to pay for it out of pocket. Reminding students not to share their passwords for if they can avoid it. We actually have a handout that recommends that they have a different password for their healthcare portal than they do for the rest of their campus accounts, such as their billing accounts or academic accounts. To keep that private, and that we inform students and our patients about privacy practices and HIPAA and FERPA and educate them on our state confidentiality laws and insurance and discuss where there might be potentials for breaches of privacy. A great website for some information is the site there for California. As you would expect, CDC has wonderful resources for providers, teens, young adults, and parents as well. These are some of the main areas of concern. All of this, and particularly our concerns about confidentiality and privacy, have been upended in our current situation. We, as well as many other universities, switched quickly to telehealth. We had our normal concerns about privacy and confidentiality were just amplified after our students were sent home. And then they're trying to have a telehealth appointment about sex, sexuality, reproductive health care issues from their home or with 5 other roommates nearby. If they're at home, there's a concern about, can people hear through the walls? We do offer some of the mail service, STI and HIV testing, and mail order prescriptions for contraception, but does that go to the house, and who's going to pick up that mail? A number of things certainly to consider, and things that we are still trying to address, and I'd love to hear how other people are addressing those concerns. This is my contact information. Please send me your questions. I'm also look forward to further discussion and learning in our Q&A section. Thank you for your attention.
That is our last speaker. I want to thank all of our speakers today and the audience for your attention. Again, I want to remind you that there will be a live question and answer session for this symposium on Friday, September 18th at 2:30 p.m. This session is now adjourned.